Chairpersons, friends, a very good afternoon to you all. I think you'll have to pardon me for my throat. I'm the victim of Delhi pollution for the last few days. Delhi, I'm sure you must have read in the news, Delhi currently is going through a very bad phase as far as the air quality is concerned. It's really horrible. Let me first congratulate Dr. Alok Singh for continuing to organize this conclave for the last many years. I have been part of this conclave in the past also, and I think it's an excellent forum to discuss the various aspects of cardiovascular diseases, both medical as well as surgical. I'll be briefly speaking on the surgical management of So I'll be briefly speaking on the surgical management of advanced heart failure. As physicians, as cardiologists, all of you know that heart failure is a challenge across the world, and same is true for our country as well. There are millions of patients suffering from various stages of heart failure, which we see in our daily practice. And the natural history of heart failure, once it is diagnosed, is not very good. It continues to progress unless treated well in time. The patient gets admitted with decompensation and finally goes into advanced heart failure. And again, if the treatment is not done, the patient finally dies. The hospital admission is a red flag, because every hospital admission is an indication that the survival of this patient is limited. And as you can see here, if patient has one admission, the survival is 50% at 2 years. So what I'm going to discuss is not the stage A, B, and C patients. I'm going to discuss patients who need treatment in stage D. As you all know, the ACCHA has classified these patients of heart failure into 4 stages from A to D. And in fact, now we need to start taking care of these patients when they are in stage A, even before they have structural heart disease, before they have symptoms. They only have the risk factors. Unfortunately, they don't come to us at that stage because there are no symptoms. But once they come to us, obviously we have to very thoroughly evaluate these patients and treat as required. So the patients which need advanced treatment are the patients who are in stage D or NYHA class 3B or class 4 symptoms. Now, why it is important to recognize what stage the patient is, because when the patient goes to stage D, as you can see, by 5 years practically every patient is dead. So I think we need to identify these patients when they have advanced heart failure in our clinic or once they get admitted. So the patient has been diagnosed with advanced heart failure. What are the treatment options? Well, there are only 2 treatment options which are available to us. One is the heart transplantation, and second is the ventricular assist devices. I must say about 15 years back, at least in India, these 2 therapies were more theoretical than practical, because we were not doing the transplants and we were not doing the LVADs. But fortunately now this has become, I would say, a standard of care for patients with advanced heart failure in our country as well. I remember when I was in UK and I, out of interest, I visited the Harefield Hospital, which was at that time was doing the largest number of transplants in the world, and this was in '94. Just out of interest, and I was thinking out of that this will never become a reality in our country. So I am wasting my time on going to Harefield Hospital and visiting transplant and all those things. And interestingly, the same month when I used to visit there, the first transplant was done in India. So it was so encouraging for me to see that news, which actually it was covered by the local media as well in UK. And I said, no, it's going to be a reality. And fortunately now it's a reality. The numbers are limited, but now there are large number of centers which are doing transplant. So we have a new era for these patients, new opportunities. We certainly have a lot of challenges, but there are new paradigms. I think this slide is probably very important for all of you as the physicians, as to how to identify patients who need to be referred for advanced heart failure clinics. Now these are the criteria by the European Society of Cardiology and the American College of Cardiology. And if patient has these features, I think you need to refer these patients for further evaluation. So patients who have been hospitalized more than twice in the last 12 months, patients with persistent class 3B or class 4 symptom, patients who have high risk biomarker profile. I think hyponatremia in patients with heart failure is a very, very bad prognostic sign. Patients where you have to escalate the diuretics when they come to your clinic. Patients where you have to down titrate the guideline directed medical therapy because of hemodynamic intolerance, again is a very important class of patients to indicate that they are in advanced heart failure. And if you have to discontinue the ACE inhibitors, the ARBs and the ARNI because of hypotension or because of renal intolerance, again it's a bad sign. And progressive renal failure with rising urea and creatinine, again very clearly indicates that this patient needs more than what the patient is currently getting. And patients with recurrent arrhythmias including ICD shocks. And also now we have many mortality risk scores which can predict the 1 year, 2 year and 5 year survival of this patient. We can use these scores to prognosticate these patients, to identify patients who should be referred for advanced heart failure treatment. So one of the scores which is used in this patient is called the heart failure survival scores. And if you look at the risk factors except the VO2 max or peak maximal oxygen uptake, the others obviously you can see in your clinic or in the hospital, and based on the risk factors, these patients can be stratified into low, medium and high. And patients who are in the high risk category, you can see the 1 year survival is less than half. The second score or second risk stratification score which is used is called Seattle heart failure model. Again, this uses various clinical parameters, the medications patient is using and certain lab values to risk stratify this patient and to see their survival in 1 year, 2 years and 5 years. This is again a very important slide because we need to find what is the golden window period for referring these patients to advanced heart failure clinic for further treatment. Obviously, you don't want to refer the patients in the early period when these patients will respond to guideline directed medical therapies. Maybe these patients will benefit from devices. But again, to repeat that these are the symptoms, if patient has these, you seriously have to think of doing further evaluation whether these patients need transplant or LVAD. And to repeat again, these are the patients who are in persistent class 3 or class 4 symptoms. When you have to down titrate or you can't use the guideline directed medical therapy, patients requiring frequent hospitalizations, patients with recurrent arrhythmias or ICD shocks and worsening renal failure. You don't want to have the patient in this category when the patient has already developed multi-organ failure or severe malnutrition and what we call as a cardiac cachexia, because by the time patient goes to this stage, even the heart transplant, either it won't be possible or LVAD, but even if you do it, the outcome is going to be poor. So this is the window period which we have to identify to refer these patients to the advanced heart failure clinic and treat these patients. Heart transplantation, I think over the years has shown excellent results, and I would say that in patients with advanced heart failure, no other therapy actually has shown the survival benefit which is afforded by heart transplantation. This is the only therapy which has shown an excellent results in the category of patients which we are talking about. So patients, imagine, who have a 50% survival at 2 years, the median survival is 13 and 14 years, the median survival is 13 and 14 years after transplant. The longest surviving patient died few years back, and he survived for 30 years after transplant. So obviously, the transplant is an excellent option in these patients, provided the patient is referred in time. The clinical parameters are obviously important, and the symptomatic status, but the symptomatic status, especially the NYHA class, we know it's a lot subjective, and what somebody says 3A maybe 3B for another physician or patient. So we need to do the objective assessment of this patient, and when the patient is referred to us for evaluation for advanced therapies, I think the two important tests which we do, one is the CPAT or the cardiopulmonary exercise testing, which basically measures the maximum oxygen consumption in the patient, and this VO2 max has been taken as a very important criteria to list these patients for transplant. And according to the International Society of Heart and Lung Transplant, patients who are intolerant to beta blockers, if the peak oxygen consumption is less than 14 milliliters per kg per minute, this patient should be listed for transplant. And patient in presence of beta blockers, this value is taken as less than 12 milliliters per kg per minute. So I think VO2 max is a very important objective assessment to assess the severity of disease in this patient, and we routinely do this in our outpatient clinic, in our heart failure clinic. The second test which we do for which patient needs to be admitted to the hospital is the right heart catheterization. So we admit the patient in ICU, float the Swan gauge catheter, and then measure various parameters. The two very important parameters which again reflect and which again tell us what is the prognosis of this patient is the transpulmonary gradient. So transpulmonary gradient is basically the difference between the mean PA pressures and the wedge pressures, and if it is more than 15 millimeters of mercury, or if the PVR is more than 3.5 Wood units, this indicates poor prognosis after transplant. But patients who have these high PA pressures and high TPG and high PVR, we put these patients on milrinone continuous infusion, monitor these parameters again on a continuous basis, and if the TPG comes down and if the PVR comes down, these patients certainly again do very well after transplant. And these have been considered as the not absolute contraindications but relative contraindications for transplant. So the challenges which we face in India for transplant is the late referral. The donor availability certainly as a challenge, it's more so in North India, but across the country. This transport of organs again is a very major challenge. We started our transplant program about 10 years back, and obviously we have retrieved organs from long distances as far as Coimbatore, Bangalore and Mumbai, but we have a window period of less than 5 hours in which we have to transport the heart and do the actual transplant. So transport again is a very important challenge, especially if you are retrieving the patient, the heart from long distances. The infrastructure, cost and manpower certainly remain challenge in India for any therapy. And the long-term management obviously includes these three important things: the immunosuppressive therapy, lifelong surveillance of rejection, and prevention of infection, because these patients are immunocompromised. Some of you must have heard recent news about the xenotransplant, a successful xenotransplant from a genetically modified pig. This certainly, as of now, is not a reality in a clinical use, but it is expected that maybe in future this might be a reality. And why it becomes important? Because the donors are limited. If you look at the number of transplant across the world, they are increasing gradually because of various reasons. But at the same time, the numbers are much less in comparison to the demand of patients who need heart transplant. So I'm not going into the other details of the transplant, but there are patients who can't have a transplant either because of the fact that the patient has certain contraindication to transplant, or because the patient can't get a donor. So we can't get a heart, and in this situation we have to evaluate the patient, and if the patient is a candidate, we offer them ventricular assist devices. So this ventricular assist devices, I'm sure some of you might be aware of this, is basically a mechanical call it a mechanical device for a mechanical heart. This is the latest one. It's called Heartbeat 3. It has, so all devices have three components. This is the pump. There's an inflow cannula which is connected to the left ventricular apex. This pump is connected to the aorta through this outflow graft. The pump sucks blood from the LV cavity and pumps into the aorta. This pump is connected through this drive line. It's called drive line outside the body to this controller, and this controller controls all the functions of this pump, and it stores all the data which we can review at any point of time. And obviously after the implantation, patient can do all normal activities at home, in the office, and in fact patient can do all the activities. We have our patients of LVAD who now actually are doing their business and flying into other countries with the LVAD. The LVADs have evolved over the years, so I would say over the last 4 years, from first generation, which were very sort of a bulky devices, to the second generation, and currently we are using third generation pumps. So this is the second generation pump, which probably has the largest experience, has been used in thousands and thousands of patients. It did have certain challenges, especially a little high incidence of thrombosis, and this was basically because of the design. And now the third generation pump is the Heartbeat 3, and this is now the most commonly used pump which we are using. And the technology which has been used in this pump certainly is better than the Heartbeat 2. The left ventricular assist devices can be used as a bridge to transplant, which basically means that you are waiting for the donor to become available. And this is the commonest cause of LVADs being used in the Western world. But in India, majority of the patients, I would say practically all the patients where we use LVAD, they get what is known as a destination therapy, which basically means that this is the final treatment for these patients, and we'll be using it where either the transplant is not an option or we can't get a heart. This is our first patient which we had used the LVAD. This was about 8 years back, Heartbeat 2. Currently, he's around 83. He celebrated his 83rd birthday, and he, in fact, travels between India and US because his daughter lives in India and is leading a good life even at the age of 83 years. And at that time, obviously, he was told that your lifespan is not more than a year. I think one important thing is that after the transplant and the LVAD, the quality of life is excellent. So to give you an idea, our first transplant boy was 17 years of age when we did about 10 years back. And after that, he completed his graduation, post-graduation, and got married. And this guy became so free to call us because he was our first patient, kind of became a VIP. He calls me one day at 10 o'clock in the night, and we normally pick up his phone, and he said ki sir aap dada ban gaye ho. I said dada ban gaye ho. So he actually got a child, and he was so excited that he called me at 10 o'clock in the night. So he's currently is 10 years post-transplant, living absolutely normal life. This patient received a LVAD, and this is I was talking about. He's from Chhattisgarh, and he's running his business, and he's traveling to actually across the globe with his LVAD. And I told him that why don't you get a transplant done now because your age is young. He said, no, I'm doing so well with the LVAD, I don't want a transplant. And just to give a case where we are having challenges in doing a transplant, though the patient actually is a right candidate for transplant. This 46-year-old male, which had operated many years back, did an aortic valve replacement. At that time, his ejection fraction was 30%. He was doing very well for a few years, but he got admitted in the local hospital on 2 occasions with heart failure and required dialysis also on one of the admissions. He was referred to us at one point of time in a very bad shape, immediately required intubation as soon as he landed in our hospital. He had to be dialyzed, and fortunately gradually improved, and we evaluated this patient and registered him for transplant. He was shifted to the ward, and we were waiting for the donor, But in the ward, after 2 days, he had cardiac arrest, had a VT, had to be resuscitated, intubated, shifted back to the ICU. Fortunately, again stabilized and got extubated, though required dialysis. And finally, we told the family that because we are not getting the heart, we should have a LVAD, though he was young patient, and young patient normally the heart transplant is the first option. So we did the HeartMate 3 LV implantation, and he did very well. This is our patient which we just discharged only 2 weeks back from Uzbekistan, a 54-year-old old male was referred for heart transplant, but the challenge in the transplant in international patients is that the international patients will not get a heart if an Indian patient is waiting for a heart. And he had severe LV dysfunction with a large LV clot, but he also had a moderate RV function. Fortunately, the RV improved with Milinon, because one of the criteria to use an LVAD is that your RV should be okay. If the RV has severe dysfunction, then LVAD can't be used. So we planned for LVAD, but while he was waiting for the funds to get transferred, one night at about 11 o'clock, he complained of severe limb pain, and when we examined, he had absent peripheral pulses. So obviously it was an embolism from the LV clot, and within 15-20 minutes he had tachypnea, dyspnea, severe metabolic acidosis, and collapsed, had to be put on inotropes. Immediately we rushed this patient to theatre, did bilateral embolectomy, and fortunately he gradually improved, and after a few days we did the HeartMate 3 implantation, and then he did well and was discharged 2 weeks back. So to summarize, heart failure is a major health problem in our country as it is in the rest of the world. The mortality in these patients with advanced heart failure is very high. Though medical and device therapy has significantly improved the survival of these patients, but patients who continue to remain in heart failure despite best medical therapy and device therapy, they should be evaluated and should be referred for heart transplant and mechanical circulatory support. Thank you very much for a patient hearing.
Sir, one question. What is the approximate cost involved in LVAD therapy?
So I think the biggest challenge for LVAD, at least in India, it applies to most of the countries except where it is covered by the insurance like US, is the cost. So HeartMate 3, the device cost is around 70 lakhs and another 10 or 12 lakhs for the hospital. So roughly it becomes around between 80 to 85 lakhs, which obviously is a pretty high cost here.
So are there any schemes, government schemes helping this?
Unfortunately, no scheme helps the LVAD so far. Though interestingly, the CGHS and a lot of these government agencies have started approving the transcatheter valves, which again are around 25-30 lakhs, and other high-end therapies. But even those agencies are not approving the LVAD as a treatment for these patients. When I say approving means they are not paying for this treatment.
Thank you, sir. Thank you for an excellent talk. Any questions from the audience?
Thank you.
Okay, sir. We wrap up this session. Over to you, Dr. Alok.
Thank you, sir, for nice deliberation. Now I request Dr. Ajay Pandey, sir, to give memento to Dr. J.S. Meharal, sir. So now, once again, I invite Dr. A.K. Singh, sir, to give memento to our chairpersons, Dr. Mohit Saxena, sir. Once again, I request Dr. A.K. Singh, sir, to give memento to Dr. Vikas Agrawal. Now I request Professor Deepak Gautam to give memento to Dr. Ramurthy Singh, sir. Once again, I request Professor Deepak Gautam to give memento to Dr. Rajiv Gupta, sir. Now I request Dr. S.N. Rai, sir, to give memento to Dr. Jiten Singh. Thank you, sir. For next session is session 4. The chairperson for the session is Dr. Ashish Jaiswal. Please come on the desk. I think Dr. Dheeraj Kishore, sir, is not here. Dr. Akhilesh is not here. Now I invite Dr. A.K. Singh, sir, to please come on the desk and chair the session.
Thank you, Dr. Alok sir, and we are moving ahead.